Line irkara illa idu Shafiq kan யோசிச்சிருந்தேன்.
Okay, doesn't matter.
Ama, I think it's only.
Madam, both of them, the Palni sir is also there. Myself, Shafiq,
Okay. Then can we start? Sir is asking.
Okay. Good morning to all of you, and welcome to this clinical neurology forum. We have been having it once a month from different centers, and this time cases will be presented from Chengalpet Medical College Hospital, from Chengalpet Medical College, and Professor Ilangovan will be the moderator. We have with us Professor Banu, who is going to be the chairperson and going to conduct the proceedings. I have great pleasure in welcoming my colleague, my friend, Professor Banu. As all of you know, she has been the director of the first director once the Institute of Neurology was created, having separated from the head of, from the Department of Neurology and Neurosurgery into Institute of Neurology and Institute of Neurosurgery, and she was the first head and director of the Institute of Neurology. Professor Banu did a Commonwealth Fellowship in the United Kingdom, and a special interest had been in epilepsy. She was involved with the conduction of epilepsy clinic in Government General Hospital, and prior to that, I think in KMC Hospital also. And she did yeoman work in organizing epilepsy in Madras Medical College General Hospital, and she also ran a bakery department within the institute itself to help people who have nothing to go by, to give them a source of work for them to do subsequently. And Professor Banu is a fellow of the Madras Medical College. She is a fellow of the Indian Academy of Neurology. She is a fellow of the Royal College of Physicians. And anything else, Madam, would I have missed out? And she is the director at present of the Institute of Neurosciences at Dr. Mehta's Hospital. And as all of you know, she's a very active and busy neurologist. She is incidentally also the secretary of the treasurer and probably the future secretary of the Indian Epilepsy Association of Chennai. I welcome you all, and I hand over to Professor Banu to take over and conduct the proceedings. Thank you, madam. Thank you. Welcome. You are not audible, madam. You are not audible. Maybe you'll have to take off your... No, you are not audible.
Mute.
Ilangovan is audible. Madam, you take off that and see.
Now?
Now you are audible.
Okay. Sir,
better.
Okay.
Yes.
Okay. Sir, you forgot to add one thing. And I would like to add that I am sir's student.
Madam, closer to the mic, madam. Closer to your mic. I mean, to your whatever mode you are using.
Better
yes.
now? Better
yes.
now?
Yes.
Okay. What I would like to add to this is I am sir's student.
Madam, இன்னும் கொஞ்சம் sound வேணும்.
Sound இல்லையா?
நீங்க முதல்ல வந்தப்ப கரெக்ட்டா இருந்தது. When you came on first, it was okay.
Hello? Can you hear me now?
Yes.
Okay. I think
yes.
This is it. Yes. Okay.
Yeah.
What I would like to add, I am sir's student from 1987 and I still continue to be his student.
அதெல்லாம் இல்ல, நாங்க தான் உங்க ஸ்டூடண்ட்.
ஐயோ இல்ல சார், ரொம்ப அநியாயம் சார்.
Sorry, let us proceed.
I'm very happy to be participating in this very elite forum by Professor V. Natarajan sir. And I would like to introduce Dr. Ilango, who is presently the Associate Professor of Neurology at Chengalpet Medical College and Hospital. And I welcome him and his team to present cases, and we'll straight away go ahead with the presentation. Thank you. And I thank Sun Pharma for giving me this opportunity also.
Madam, introduce Professor Ilangovan, madam.
Avladha introduction ku vandirukku sir. Dr. Ilangovan did his undergraduation in Stanley Medical College. Subsequently, he was an assistant professor in Tanjavur, and later now is associate professor and the HOD Chengalpet Medical College, Chengalpet. So, and now they have started the DM neurology courses also. Congratulations to the department. I think we will take it from there. Over to you,
Yeah.
Dr. Ilangovan.
And he is also an ebullient young neurologist. Okay.
Yes, very young
Thank you, sir.
neurologist. Thank you.
Thank you, sir. Thank you, madam. Thank
I
you.
got this
my
very short
respected-
CV only. I didn't get a detailed CV, so I'm telling you short only.
No problem.
That's okay, madam.
Okay.
That's okay.
Okay. Thank you.
Respected my teacher, Professor Dr. VN sir, and Professor Banu madam, and all my respected faculties. Good morning to all. We are a newborn child like that. Our institute, Sengalpet Government Medical College. I like to thank Professor VN sir, my teacher, and given us the opportunity to present the case. Thank you very much, sir. Thank you, madam. I will ask our postgraduate.
Wish you all the best.
Thank you, sir. Thank you, madam.
Good morning, sir.
I asked to focus on my Sengalpet Medical College colleagues.
Madam will call for the first presenter. Madam will call.
Okay, madam, call the
I think
presenter.
Ilangon can call. No issue.
Okay, no problem.
Okay.
No problem.
Mine is
Dr.
not going into that. I
No
think.
problem.
Okay. Let
Okay, Dr.
me-
Magish, start to present the case.
Yeah. I think you please tell the name of the PG and present because that is not
Magishwari.
opening in my.
Yes, sir. Good morning, sir.
Good morning.
Sir,
You
video
try
is
to-
not. Yes, sir.
Your video is not clear, Dr. Magishwari.
Sir, video is not coming, sir.
That's why I'm asking.
Yes, sir. Sir, is it
Okay.
visible, sir?
Yes,
Okay.
please. Yes, please.
Good morning, sir. I thank my professors, Chief Sir Elangovan sir, and Associate Professor Bala sir, and Assistant Professor Hariharan sir, and my department PGs for giving me this opportunity to present the case. Today, I am going to present an interesting case of ataxia. A 24-year-old right-handed male who is educated up to degree, clerical work by occupation, was bought by his uncle with the chief complaints of unsteadiness while walking since 3 years. His history of present illness, the patient was apparently normal 3 years back. He had fever for 4 to 5 days, high grade, associated with chills and rigors. On the 5th day of the fever morning, when he placed his feet on the ground, he was unable to perceive the ground sensation and had diminished the perception of hot and cold water in the feet. Later, the patient got up and walked with the support of the wall because of his unsteadiness. However, he could clear the ground. He had unsteadiness while walking and swaying to either side. His unsteadiness was so severe that he could not without attendant's help. However, he could sit without support. Next day, while bathing, he noticed worsening of the unsteadiness upon closure of eyes, which is not
Sir, request
associated
all
with
others to mute, please. Please.
Continue, ma'am.
Next day, while bathing, he noticed worsening of unsteadiness upon closure of his eyes, which is not associated with spinning sensation, tinnitus, ear discharge, and diminished hearing. And there is no history of clumsiness while taking coffee cup or smearing of food. Patient also noticed slurring of speech. When the visitors has visited him, they asked whether he was drunk, as his speech resembled drunken man. However, the attendants could understand his speech and he was able to comprehend what others were talking to him. He was taken to nearby hospital, admitted for 20 days where the IV drips injectables were given. MRI brain with spine was taken, which was reported as normal, and discharged with the medications. He lost all the records. Over the period of 3 months, his unsteadiness improved incompletely. That is, he would walk alone without support, later static, and he's on oral vitamin B complex tablets. On the end of 3 months, his functional status was he could walk alone with persistent unsteadiness, which is not associated with falls, diminished perception of hot and cold sensation in the feet, and slurring of speech. He did not attempt to go to work because of his unsteadiness. He underwent multiple consultations for the above symptoms. Later, he presented to us with the unaware slippage of slippers, and during buttoning and unbuttoning, he had clumsiness, which increases upon eye closure or takes off his eyes from the buttoning and unbuttoning. He is able to perceive mosquito bites, cloth sensation in the other body regions, and no history of band-like sensation on the trunk and electric shock-like sensation on bending the neck, and no history of pinprick burning sensation of the feet. No history of difficulty in mixing the food or spillage, no history of difficulty in combing hair or wearing shirt, turning in bed and lifting a neck from pillow. No history of difficulty in getting up from squatting position. No history, it is not associated with any thinning, twitching, cramps and exercise intolerance, and not associated with any tremulousness on reaching for coffee cup, glass of water or smearing of food. He also noticed decreased hearing in both ears from 2 years, which is insidious in onset, progressive. Initially, he could hear whispering sounds. Later, from 6 months, attenders had to talk loudly, which is not associated with tinnitus, spinning sensation, ear discharge, and any exposure to loud sounds continuously. Patient is able to perceive the orders normally. He is able to see the objects, identify the colors, and no bumping over the objects. No history of drooping of eyelids, difficulty in moving the eyeballs in all directions, and double vision. And he is able to chew the food and appreciate sensation over the face. And no history of deviation of angle of mouth, drooling of saliva, no history of difficulty in swallowing food, no choking sensation, hoarseness of voice, no nasal regurgitation and nasal speech. He is able to turn his head from side to side, and he is able to protrude his tongue and manipulate food. And there is no history of bowel and bladder disturbances, and there is no history of abnormal sweatings, dryness of skin, hair loss and postural giddiness, no memory disturbances, loss of consciousness, behavior and emotional disturbance, no hallucinations, seizures, no history of headache, vomiting or neck stiffness, no history of recent trauma to the head, loss of weight, appetite, no history of cold intolerance, weight gain, dryness of the skin. Past history, no history of similar complaints in the past, and there is no history of hypertension, diabetes, tuberculosis, coronary artery disease, hypothyroidism, or cerebrovascular disease, and no history of native medicine intake. Family history, no history of similar complaints in the family members. His father was diagnosed as CEDP on 2016. He was currently on tablet azathioprine 50 milligrams OD, and personal history, he's a non-vegetarian, not an alcoholic and smoker. His sleep was normal and regular. Summary, a 24-year-old male presented with acute onset of fever, provoked diminished distal sensations with ataxia, dysarthria, which was incompletely improved over 3 months, later static, with bilateral progressive hearing loss for 2 years, without motor weakness, extrapyramidal and other cranial nerve involvements, autonomic and cognitive impairment.
Do you want to discuss here, doctor?
Yes, madam. Yes, madam.
Yes. Yes.
Madam has the patient presented with from 3 years with the diminished perception of the ground sensation and hot and cold. This could
Mugileswari,
be...
1 minute.
Sir.
Are you going to discuss or you want others to discuss? It is your choice.
Sir, I only will discuss, sir.
Pardon?
Sir, it's me. I will discuss, sir.
Banu madam, you can decide whether to throw open for the audience to comment or whether she can go ahead.
Okay. Anybody else wants to discuss this case?
Madam, Madam
how do
Anand
you
here.
want?
Anand speaking. Hello.
Yes,
Madam.
yes, please.
The history is suggestive of in the presence of distal sensation being absent and ataxia. I would first consider dorsal column involvement or a peripheral nerve involvement. Since it is associated with dysarthria, which has been static with the progressive hearing loss, I would like to include the central nervous system structures like cerebellum, along with some vestibulocochlear involvement in this patient. So I would probably stick on with sensory ataxia because of the structures involved, like predominantly the posterior column sensation. And because since the patient has difficulty in walking in the dark and that unsteadiness,
Yes.
I would place my gut feeling on the based on the history on the posterior column involvement, predominantly sensory ataxia.
Okay. And what about how are we going to explain the dysarthria with sensory ataxia?
Dysarthria, sensory ataxia. If dysarthria is associated with sensory ataxia, I think we should include the cerebellum also, cerebellar structures.
Yeah, or any other, because they from the history there doesn't seem to be any pyramidal or extra pyramidal or cranial involvement. So I think probably cerebellum also may be included. I think, sir, do you want to add anything, sir?
Yeah, I can. I shall.
Yes,
the point is, I know about this patient, but that does not matter. I mean, to some extent, I don't know the full, but I think we need to discuss certain issues here.
Yes, sir.
Yes, as Anand said, he has certainly a sensory ataxia, and it is evident that he has the dysarthria.
Yes.
But apart from that, she also mentioned that he has clumsiness in buttoning and unbuttoning also.
Okay.
So whether there is an added cerebella in addition to sensory is subject to verification by science.
Okay.
And further, she also mentioned that he has been losing hearing.
Yeah.
So that also has to be taken into account. But what is most interesting to me is the onset. He had 5 days of fever. On the 5th day of fever, he develops an acute unsteadiness, an acute sensory ataxia for all that matters. And the other important point is he improved. He improved over 3 months, and he was able to walk independently from a position where he was not able to walk. And thereafter, he has been static. He has been static till now. There is no worsening in that condition. So the onset was acute to subacute, significant ataxia, which improved partially, as she mentioned, and thereafter static, with no worsening of that ataxia or the dysarthria, but with a new symptom probably developing a loss of hearing or diminished hearing. So this is the picture.
Yes.
So I think whomsoever wants to okay, I'll tell you what I thought. I thought it was an acute demyelinating illness.
Sir, with
can
I just add one thing, sir? Sir, do you take the history of CIDP in the father?
Wait a minute. I have not come to that. See, sorry. That needs more elaboration. I'm coming to that.
Okay. Yes.
I'm coming to that. First, let's discuss this person. This person has a subacute to acute onset on the 5th day of fever. So it's a para-infective, possibly a demyelination, which causes a sensory ataxia. So it's a sensory variant of a GBS like picture. And he improved also with or without steroids. He was given steroids and he did improve. And has remained the same, though the improvement was partial. Dysarthria, we need to find out whether it was part of it at that time itself. It could be, if it is one of those syndromes which go with acute demyelinating illness. But what is a bit confounding is that progressive loss of hearing in the last 2 years. That's one thing we'll have to consider. But otherwise, based on this history as given, my consideration would be it's a acute subacute demyelinating illness related to the fever. One.
Yes, sir.
Of course, we go with the history that it was fever that caused it. He is very specific about it and he has improved. That is very important. Now, the second point is going to the family history. Now, what we need to ask from the presenter is, what is the CIDP business? Where was he diagnosed? What were the features at that time? How has he done after the diagnosis? What treatment was given? These details need to be known. And then perhaps since I have a partial information on this case, so I don't want to discuss further. I would request others to discuss. but I think this is how it has to be led. The discussion has to go on like that. Now we can ask the presenter Mugileswari to give the whatever details you have regarding the patient's father. Can you
Sir.
provide that, please?
Yes, sir.
At least the mode, what we need at least is the mode of onset and the progression, and if at all whether there was any improvement with treatment in the father. I do
Yes.
know that the father was admitted and treated at the Institute of Neurology, Chennai. So I think you will have to give some details regarding that.
Yes, sir. Yes, sir.
And when, how long ago?
About 12 years ago, sir. 12
Yeah,
years
not
ago.
to me, not to me. You just
Yes.
you present that history, please.
His father has difficulty in walking since 12 years ago. He has difficulty in using both his upper limbs and the lower limbs, and he had also difficulty in wearing and mixing the food and taking the objects. But there is no muscle twitchings or any atrophy. He was not a diabetic hypertensive, and his he was examined. He was examined. His bulk of right deltoid supraspinatus wasting is present, and the tone is normal. His shoulder examination power is 1/5 in both sides. His elbow power is 3/5 in both sides, and wrist is 4-5 in both sides, and hip is 1/5 in right side, and left side is 2/5. Knee is 1/5 in right side, left 2/5. Ankle power is 3/5 in both sides, and reflexes are absent in biceps, triceps, supinator, knee, ankle, abdomen, and his plantars are flexors. And he was tested for CSF protein, which is 26, and CSF pyruvate, which is 2.1, and the serum pyruvate levels as 1.2, and immune profile was negative, and his routine blood investigations was normal. He was subjected to EMG, which showed small amplitude of Q maps and complete interference pattern with no spontaneous activity. Later, he was subjected to nerve and muscle biopsy, which showed neurogenic atrophy of vastus lateralis. Later, he was started on steroids, which he did not improve. Later, he was given azathioprine, which he was currently on, and physiotherapy was advised.
What is his present status?
His present status, he is bedbound. He could not lift his neck, and he could not move. His attendants are only helping him to sit up and feed him, and but he was able to communicate, madam. All the daily activities, he was bedbound, madam, since 4 years.
Do you want to discuss with all this now, Mugileswari?
Yes, madam.
Please go ahead.
No, does somebody else wants to discuss? There are a lot of people in the audience who will
Yes.
come forward to discuss.
Yes. Anybody wants to discuss?
Anand, can he continue?
Yes, sir. Sir, father's history may be suggestive of a CIDP, but what is the nerve conduction? Was it demyelinating? They say she says it's an axonal CMAP being reduced. Was it a demyelination? Was there a conduction block in the nerve conduction study? Which I would be interested to know, sir. And whether how long was the illness the father had? And the CSF picture is not suggestive of an albinocytological dissociation. The serum, the CSF protein seems to be quite normal only in him. But how far what was any immunofixation electrophoresis was done?
Any biopsy? No biopsy.
No, biopsy was done, which just showed a vastus neurogenic atrophy of the vastus lateralis. But
I think that was only a muscle or no biopsy.
Both they have did, but now biopsy they didn't comment on what has been done, madam. But both are done.
Oh.
And serum protein electrophoresis also done, madam, which was normal.
Okay.
Any coexistent vasculitis we have to look into, sir.
Immunological profile also we have done, madam. They have done, it has been negative.
Sir, shall we take it forward? Anand,
But
yes.
As you
how
please,
far-
madam. You are the chair.
Okay.
You
No,
can
no,
take
no.
it as
I'm
you
just
want.
no. I'm just thinking there's one other case to be presented. That's all. Anand, please finish.
But how-
Please
how
go
You
ahead.
have enough time. You have enough
Okay.
time. Don't worry. Be
Okay.
worried about the time.
Okay.
Time
Okay.
is not a
Okay.
factor at all.
how far
Okay.
the father's illness comes into the patient's clinical picture history is very difficult to say, madam, at this juncture.
Yes. Yes. Yes.
So because of that, can somebody else suggest anything else in relation to this person's presentation? Any thought process? Doesn't matter what it is, just to know.
Sir,
what-
I would think of a Friedreich's ataxia, sir, in the presence of hearing loss and cerebellar involvement.
Yeah, that is
Cerebellar.
fine. See, the problem with the degenerative disorder as she has presented is the fairly acute onset or subacute onset and the
Subacute onset.
improvement and the improvement.
Improvement.
Most important is the improvement.
Improvement.
Yeah.
Partial.
See, for any degenerative disorder, you would not expect that amount of improvement that she has said. A person was unable to stand and walk initially on the 5th day, subsequently did improve and he was able to partially do. He was independent. He was able to walk and still is able to. So that degree of improvement, you will have to consider what are the differential diagnoses you are going to consider that, because it's very difficult to fit in that with the degenerative disorders.
And that progressive hearing loss over 2 years subsequently.
Ramkrishnan, sir.
Yes. Yes, Ramkrishnan. Go ahead,
Vanga, TCR.
Ramkrishnan.
Madam,
Yeah.
sir, we combine both the illness of this patient and that of the father. It predominantly looks like a neuropathy, lower motor neuron involvement, except for the dysarthria in this patient. Father has predominant motor involvement, and the investigations has not shown any features of an inflammation. Either for CSF protein is normal, the muscle biopsy has shown only neurogenic atrophy, and moreover, he has not shown any improvement with treatment. This man has presented with an acute illness which is precipitated by a febrile illness, and he has improved and subsequently he has not improved. He has remained static. So if we put together, my thought process is some form of an inherited neuropathy, like in father it has presented with the motor illness. Here it has presented with the sensory form. And with steroids, we know leukodystrophies, which will present following a febrile illness, they will improve to a certain extent with steroids, and subsequently they may remain either static or deteriorate. This is what I feel, sir.
You think it's a leukodystrophy?
No, sir, not a leukodystrophy. Clinically, it's a lower motor neuron involvement only, sir. It's more like a sensory ataxic neuropathy. I feel it's more like an inherited disorder which is presented with the motor involvement in the father and with the sensory involvement in this man, which has been precipitated by a febrile illness.
So was this patient put on steroids immediately after the febrile illness for the improvement to take place?
Yes, of course.
Yes.
That history is there.
Yes, sir. Okay.
TCR Ramakrishnan, what
Sir.
about the hearing loss, Ramakrishnan?
The hearing loss, I feel that is also could be sensory neural hearing loss, which is which we see in some form of hereditary neuropathy. That is what I think, sir.
So that's the problem in both father and mother. Both, father and son, both of them have a neuropathy, inherited neuropathy.
Yes, sir.
Okay, good thinking.
Sir,
Fine.
sir, may I, Vijayan?
Yes.
Please,
Yes.
Vijayan, you are welcome.
Yes.
That's
Sir,
why we want you.
again, thinking on lines of what Dr. TCR told, it's genetically inherited ataxia, and that's very clear here. So genetically, because multi-axial involvement is there, cerebellum is involved, hearing is involved, and there is a sensory ataxia. And the father, there has been a predominant motor neuropathy, which is not responding to medication. For this patient also, it seems to have only transiently improved with the steroids, which is known to occur in most of the degenerative illness. It looks like a inherited degenerative spinocerebellar ataxia. Now, only genetic answers would be there.
Sir, I would also go with an inherited disease present both in the father and the son, maybe a different, maybe phenotypically different, but I would also go along with that.
Thank you, madam.
Thank you. So shall we go to the presenter?
Madam, you
Dr.
decided, go ahead,
yes,
madam.
sir. Dr. Ilongavan, it's your patient. Do you think you want more discussion or shall we proceed?
Shall we proceed, madam? You can proceed, madam.
Correct, fine.
Okay. Dr. Mogaleshwari, please
Madam,
proceed.
yes, madam.
Yes.
Madam, in this case, okay, madam. Shall I proceed, madam?
Yes, yes, please.
Here the structures involved with the peripheral sensory fibers, large fiber greater than small fiber and its connections, cerebellar and its connections, and eighth cranial nerve. This ataxia could be both sensory ataxia and cerebellar ataxia, which can be confirmed on examination. And our probable diagnosis is demyelinating illness, para-infectious, which can be due to multi-axial involvement, acute disseminated encephalomyelitis, Guillain-Barré syndrome ataxic variant. But as the improvement is partial, we are not, these are the points against acute disseminated encephalomyelitis and Guillain-Barré syndrome ataxic variant. But I am considering mitochondrial, madam, because he's a male patient, fever provoked, and there is a progressive hearing loss over 2 years. And there is also cerebellar involvement. On physical examination, the patient is conscious, oriented, and cooperative, moderately built and nourished, no pallor, icterus, cyanosis, clubbing, and edema, lymphadenopathy, no neurocutaneous markers, no trophic ulcers, skin rashes. His vitals, temperature is febrile, pulse rate 86 beats per minute, regular, normal volume, blood pressure is 110/80 millimeters on both sitting and 3 minutes of standing. There is no postural drop. Respiratory rate is 18 beats per minute, cycles per minute, regular and rhythm. Rhythmic nervous system examination. He's a right-handed person, has higher mental functions. Patient is conscious, oriented to time, place, person. MMSE is 30/30. And his speech is normal, no dysarthria. Language is normal. Cranial nerve examination, his first cranial nerve is normal. Second cranial nerve, his visual acuity is 6/6 in both sides. His field of vision is normal in both sides. Color vision is normal in both sides. Fundus examination is normal. There is no retinitis pigmentosa or optic atrophy or any cataract. Third, 3, 4, and 6th cranial nerve, there is no ptosis. His extraocular movements was full range. And the saccades normal, pursuits normal, no nystagmus. Pupils is 2 millimeters reacting to light bilaterally. Fifth cranial nerve, motor is normal, sensory normal. His reflexes corneal, conjunctival, and jaw jerk absent. Rest of the reflexes is normal. Seventh cranial nerve, motor, is able to normal in both sides, and taste sensation is also normal. Corneal, conjunctival, reflex normal. Eighth cranial nerve, Rennie's test positive, that is air conduction is greater than bone conduction in both sides. Weber, there is no lateralization, and ABC test, there is decreased in both sides. 9 and 10, uvula is in mid position, palatal and pharyngeal movements are normal, gag reflex is present bilaterally, and the 11th cranial nerve, the shrugging of shoulder and turning is normal. Regarding 12th, no deviation of tongue, fibrillation or wasting. Coming to the motor system examination, no generalized wasting. Coming to the tone, right and left upper limb and lower limb hypotonia. However, left lower limb hypotonia is more than the right lower limb. And the power, neck flexor and extensor normal, trunk muscles power is normal, and upper limbs power of shoulder abduction, adduction, extension, and flexion is 5/5 both sides. Elbow flexion extension is 5/5 on both sides. Wrist flexion extension is 5/5 on both sides. Hand grip is 100% on both sides. In lower limb, hip flexion, extension, abduction, and adduction is 5/5 on both sides. Knee flexion and extension is 5/5 on both sides. Ankle dorsiflexion and plantar flexion is 5/5 on both sides. And reflexes, superficial reflexes, corneal, conjunctival, abdominal, and cremastic reflexes were present. Plantars were flexor both sides. Is deep tendon reflexes, biceps is areflexia on both sides on reinforcement. Triceps, right side not present, left side just present. Supinator, right and left, it is absent. Knee absent and ankle absent. And his spinothalamic tract sensations, pain and temperature diminished in graded manner up to ankles. Rest of the body regions, it is normal. The posterior column sensations, touch, vibration, and joint position sense diminished in graded manner up to ankles. And his rhombus test was positive. And the cortical sensations, tactile 2-point stereognosis, graphesthesia is intact. Cerebellum, there is no head perturbation, no nystagmus, no dysarthria. His finger nose test is normal, finger test is normal, no dysdiadochokinesia. Hill-Shin test is normal. Meninges, there is no neck rigidity. Kernick-Sen is negative. Bredninski is negative. Gait is ataxic gait. Turning difficulty is present. Spine and skull normal. Autonomic nervous system is normal. Skin and head, there is no skin and hair changes. Peripheral nervous system, there is no nerve thickening. Other system examination, cardiovascular, respiratory, and abdomen is normal. On summary of the examination, he had bilateral sensorineural hearing loss, hypotonia, areflexia in both sides, distal sensory loss in graded manner with no weakness, cerebellar, extrapyramidal, and cognitive features. Shall I proceed, madam?
Anybody wants to discuss? Anand?
Madam,
Now, yeah, tell me. What is the
predominantly
difference?
there is no motor involvement.
Yeah.
There is a predominant sensory involvement. But the confusing picture here is in the history, it is said that the patient had dysarthria. On cerebellar examination, there is no dysarthria.
No.
Does it mean it's the absence of scanning speech, or I'm not able to make it out, madam, because
we can ask her to tell. Mukleshwari, can you please clarify, is the speech normal or are there any changes in the speech?
Ma'am, I will show the audio video, madam.
Okay. Yeah, please.
Mukleshwari, you'll have to increase the audio volume. Volume has to be increased.
Sir, this is the maximum, sir. Madam, shall I repeat it, madam?
Repeat, but again, audio is not clear.
Yes.
Is there some backup audio or something which you can share?
Yes, madam. Maximum. One minute, sir.
So I'm not able to tell anything about this speech.
I'm not convinced about the cerebellar type of speech, madam.
Yes,
Okay.
madam.
Right. Okay. Is his speech normal? I think there's some change in speech. Hello?
Yes, madam.
I find there is some dysarthria.
Yeah,
some kind
correct.
See,
There's some alteration in the speech.
hesitant for the word output, madam, actually.
Yeah.
Hesitation
Especially-
for the word output is there.
Not only
Madam,
that,
that
it was
too-
also splitting of the, yeah.
That too, he's only intermittently he had that dysarthria, madam. Whenever he talks about his things and all, he initially he doesn't have any dysarthria, madam. Later, after 4 to 5 sentences later only he has that kind of dysarthria, madam. That is slurring, madam.
Okay. Anand, you want to add anything? Me, I will go with HSN. Yes. Hello?
There is nothing to add, madam. I think you can go ahead. Actually,
Okay.
Madam,
Sir,
shall I proceed, madam?
VN sir, before you
Yeah,
proceed.
let her go ahead. As I said,
Okay.
I know something about the patient, so I don't want to comment.
Dr. Ramakrishnan and Dr. Vijayan, do you want to take it from your history to findings now?
Nothing more, madam. It just eliminates the cerebellar. Otherwise,
That's
the
it.
same diagnosis holds. That's all.
Yeah, yeah. I also will go with the HSN plus hearing loss, probably one type of hereditary sensory neuropathy with hearing loss. The features are difficult to explain, but still this will be my nearest fit. Yes, go ahead, Dr. Mugileshwari.
Yes, madam. Yes, madam. Here, the structures again involved is large fiber and small fiber ends connections, large fiber more than small fiber, and 8th cranial nerve. This is sensory ataxic neuropathy with hearing loss. And my probable diagnosis is Guillain-Barré syndrome, sensory ataxic variant, or mitochondrial ataxia. And routine investigations was normal, and RFT, LFT. His immunological profile was like, sir.
Mugileshwari,
Sir.
sorry. As I told you, I know about the patient, but see, everybody was pointing out to a sensory ataxia and probably going by his father's problem, it was inherited neuropathy. I'm sorry. Okay, inherited neuropathy.
Yes,
now,
sir.
why do you bring in mitochondrial? What made you think of a mitochondrial ataxia in this patient?
Sir, as he's a male patient, and because of sensory neural hearing loss that is progressive, and also his now it may be due to both considering history and examination. I thought of mitochondria, sir.
Okay, because nobody else mentioned it, you are bringing in that, so I just wanted to know what was the reason.
Only one objection, sir. Here.
Yeah.
Can the father pass on mitochondrial DNA to his son? That is the only objection.
Yes.
Maybe very rarely, but
good question.
I think
question,
it would have been, if mother and son would have been more appropriate rather than that's the reason why I didn't bring in mitochondrial.
Mugileshwari, why did you not think of some type of hereditary sensory neuropathy? Anything specific from your history and findings? No, not with the investigation. Before that.
Yes, madam.
Or did you think about it?
Sorry,
HSN.
madam. HSN is because father and mother has cities and other features are not suggestive of hereditary sensory neuropathy, madam. Like it's not so long-standing, no, madam.
Sometimes they occur later, no?
Yes,
Third
madam.
decade, second decade, and it can be progressive. Though the father was diagnosed as CADP.
Yes, madam.
Okay,
but improvement, madam, because
but father did not improve.
Father did not improve, but the patient has improved.
Some improvement.
It
Yeah,
became static, no, madam.
I do agree.
Yes,
but
madam.
I'm just wondering whether because of the subsequent onset of hearing loss in the presence of a neuropathic illness,
yes, madam,
purely sensory with no motor.
Yes, madam.
Whether did you consider sensory neuropathy? If not, you proceed. No issues.
I didn't consider, madam.
Okay, proceed.
Okay, madam. And his plasma lactate levels was 46.5 milligram per deciliter, and pyruvate levels was 1.20 milligram per deciliter, which was 3 times more than the normal lactate levels. His CSF, he was not willing, madam, because he's multiple. He has gone consultations there. He was taken, so he was not willing this time. His ECG 2D echo was normal, chest X-ray normal. His cardiogram revealed moderate sensory neural hearing loss bilateral. MRI brain was normal report. His genetic testing results were awaited. And this is the MRI brain sagittal view. Though the MRI was reported as normal, but I could find some atrophy in the cerebellar region, madam. This is the MRI brain axial view, particularly that midbrain, middle Birmian and his atrophy is there, madam.
Let's see.
His Vera, it is not obtained bilaterally. VEP is normal on both sides. Sensory snaps are not obtained in all the limbs. Motor, CMAPs and F waves are not normal in all the limbs.
Are normal.
No, are normal in all the limbs.
Okay.
This is the nerve conduction study, madam.
Right.
Which is normal.
Those are quite good.
Mugileshwari, what about
Sir?
the EMG in this patient? You told about the EMG in the father. What about the EMG in this patient?
Sir, EMG, because he's I don't want any needle. He's telling, sir, don't put me on any needle procedures.
So not done.
Yes, sir, not done, sir.
Okay.
Yes. Biopsy?
Biopsy we did, madam.
Okay, before that, any discussion you want?
Yes, madam.
Anand?
No, you go ahead with the biopsy findings.
Okay,
Doesn't matter.
okay, okay. Go ahead.
Here we suspected and muscle biopsy revealed only mild neurogenic atrophy, madam.
Tell everybody, not just me. Yes.
Hello, madam.
Yes. Host, can you please mute everybody except the presenter? Hello? Yes, go ahead. Muscle biopsy.
Yes, madam. Muscle biopsy here, mild neurogenic atrophy only given, madam.
Okay. And what about no biopsy? Not done.
Not
No,
done,
you
madam.
said no report or not done?
Yeah, not now biopsy not done, madam. Only muscle biopsy done, madam.
Did they do any special stains or anything?
Yes,
Ragged,
madam.
ragged fibers not seen.
Yes,
Okay.
madam. Cox and SDH.
Okay,
And,
okay. So they have done.
SDH and ADH done, madam.
Okay. So where are we after the muscle biopsy? It's not contributed much.
Yes, madam.
So and it is at least excluded. It is excluded certain disorders.
Yes,
Yes.
madam.
Yes, please go ahead.
Then, yes, madam. Considering all these things, we thought of sensory ataxic variant of the GBS, madam, because partial improvement is there.
Hmm.
And but
What, Mugleswari?
odd thing is here
What you have
bilateral
reversed your
progress,
thinking
sir.
now?
Sir,
You have reversed your thinking now.
still, sir, still I'm going to consider mitochondrial loan, sir, because of this bilateral sensory neural hearing loss, and he's a male patient and fever provoked. That is my thought process, sir. And also, Paul spectrum disorders, it can be sensory ataxic neuropathy can occur, madam. Because
Okay.
in my,
What about HSN type 1E? Yeah? Which one is that with the hearing loss? Hereditary sensory neuropathy.
three, madam.
Okay. I think 1E also. HSN,
3
not
and
HMSN.
4, madam.
Sensory neuropathy type 1E is okay. Go ahead.
But progressive, no, madam. That is the thing.
Some
That's what-
illness had brought it on. Partial improvement,
Yes,
static.
madam. Yes, madam.
Yeah, it is
This
against HMSN, but I mean HSN.
Yes,
But with the
madam.
family history of sensory hearing loss and sensory symptoms in the, I mean, predominant sensory in the father.
Yes, madam.
Okay, it's my thing. Okay.
Because of this, I thought of Paul spectrum disorders only, madam. Predominant sensory neuropathy with bilateral hearing loss, which is progressive, and in further follow up later, again I will repeat muscle
Okay.
biopsy, madam.
Okay. Dr. Ilongovan, you want to?
Madam,
Anybody else? No, what about
Sir,
Ramakrishnan Vijayan? No,
Ramakrishnan.
they can continue.
Yeah.
Ramakrishnan Vijayan, interested to hear
Sir,
you.
only objection is father to son. That doesn't fit in at all.
Okay.
Yeah, but what are the features which go in as far as the father is concerned, which goes with whatever we are thinking of, let's say, a mitochondrial problem?
I'm not for mitochondrial, sir. Definitely not for mitochondrial. If you include the father in the diagnosis, definitely not for mitochondrial. Mother,
Me
son,
too, not for mitochondrial, sir.
maybe
Okay, what
it's
about
hereditary induced
Ramakrishnan?
neuropathy. That's all.
Ramakrishnan,
Sir,
Anand.
madam, I also feel Sangat Parasamy. Mitochondrial less likely, madam. And clinical features are also not in favor, but for Golgi spectrum disorder, I don't know fully, madam. There is no, the fundus wise, there is no retinitis pigmentosa.
Yeah.
There is no short stature. There are no other organ involvement also, madam.
Yes,
And
yes.
and what is the gene test? Dr. Mugileswari told what they have planned, madam, what they have done.
Gene
They've
testing
not
for
got
small
res-
spectrum has planned, sir, but results are not awaited, sir.
No, what test did you send?
Paul G spectrum genes
Okay.
only, madam.
Okay.
Ramakrishnan,
Sir,
see, what Mugileswari will say is that the
Yes.
pyruvate is increased in both the father and son.
yes,
What
sir,
have
yes.
you to say for that? That's what she told me. That's why I'm asking.
Yeah, she's actually she had put the values, but subsequently was not discussed. I do agree, sir.
Sir,
So-
I really don't know, sir. But the thing
So-
is that from my experience at CSF pyruvate and all, when we collect the sample, it has to be done immediately, sir. When we do CSF lactate or pyruvate, we will tell the lab beforehand that we are going to send the sample.
I agree, there is a lot of
nice
lacunae.
containers.
There is a lot of lacunae, and I'm not sure whether it was a
If I may-
serum sample or a CSF sample. At least as the
so-
son.
So
Sir,
it is not fitting in clinically with, sir. Just based on pyruvate value alone, I don't know whether to consider a
Sir,
mitochondrial disorder.
if I may, I also strongly agree with that. Serum pyruvate lactate, very hard to interpret unless done immediately, unless carried in with an ice pack. Otherwise, I don't think it's based on that alone we can diagnose this as
Okay.
mitochondrial.
One more
Sir.
confounding factor is, see, we have been talking of probably inherited problem, sensory. But the
Yes, sir.
father presented predominantly with proximal
motor.
weakness.
Yes, sir, yes, sir.
His presentation was proximal weakness both in the upper limb and the lower limb.
Yes,
There
sir.
was
Yes,
she mentioned the power which was done at the Institute of Neurology, and it was significant proximal weakness with absent reflexes. So it was a
Yes, sir.
motor problem as it was presented and not a sensory problem.
yes, sir. Yes, sir.
sir, I am Dr. Meghanda.
Yes,
Yes,
sir.
please, sir. Welcome.
Good morning, sir. I just wanted to add that I remember some 25 years back when we presented to Dr. Rajasekhar Nayak. You remember? He was
Yes,
at
yes, go
Trivandrum.
ahead, sir.
Yes, sir. He was there, sir, at that time, and he said that you should rule out hexosaminidase A deficiency in all these cases. In order to prove that, as Asogan pointed out, that you have to do it immediately. CSF to be taken, and the level should be measured immediately. And for that, you send the patient to Trivandrum, we will do it. And that's what he said. And again, he said all the features like sensory ataxia, hearing loss, and you have to rule out hexosaminidase A deficiency. I don't know. We were not very much. The patient was not willing to go to Trivandrum, and we got lost. But that was a clue he gave. And again, the father to son is more in favor for autosomal dominant type. Autosomal dominant variety of cerebellar ataxia with varying features. That is a problem rather than the mitochondrial problem.
The father's presentation is the problem. That is confusing. Otherwise, as Mugileswari will say, the patient has a sense, I am speaking for her, has sensory ataxia dysarthria. So why not this be considered as a SANDO, sensory ataxia dysarthria ophthalmoparesis syndrome? Only thing is there is no ophthalmoparesis. That was my objection also. My main objection was the father's presentation did not fit in at all. So, but still we are left with what she has presented, ataxic neuropathy spectrum of Golgi disorders, wherein you can have sensory ataxia, dysarthria, and hearing loss. Ophthalmoparesis is not there, which is not required, of course. There are different spectrums of Golgi presentation. This I had verified after that. After I had discussed with her, I referred, and this was what I found. So what I would probably consider, leaving apart the father, is whether this could be a Pol-G spectrum problem, Pol-G1 involvement, mutation in that. And some of the pediatricians, geneticians, and those who are experts in inherited disorders will have to tell us, is it possible that this still could be a Pol-G? Yes, Meghanan sir, Vijayan, Ramakrishnan, Banu madam, can this be a Pol-G? That's what she has said now. She has sent a genetic analysis for Pol-G.
I don't know, sir. I'll have to read up about it, sir.
Pol-G
Ataxic neuropathy
mutations,
spectrum can occur, but more than that,
Pol-G mutations can have
Yeah.
associated seizures also, no, sir?
Yes, correct.
yeah, that
No,
can also be
no,
there.
no.
Myoclonic epilepsy also has been
Yeah,
said,
let us go with the features presented and say whether this could be Pol-G. Absence may be there. So many features may be absent. What, Ramakrishnan?
Sir, whomever I have seen, they have presented with the developmental delay, seizures, like that only, sir. So I'm really not aware of a Pol-G disorder presenting as a sensory neuropathy, sir.
Yeah, it's an ataxic neuropathy spectrum. Pol-G
Yes, sir.
can present as CPEO spectrum ataxic. நான் ரெஃபர் பண்ணது சொல்றேன்ப்பா, எனக்கு தெரியாது உள்ளபடி. I don't know. அவங்ககிட்ட பேசினதுக்கு அப்புறம் அவங்க சொன்னதுக்கு அப்புறம் when I went back and referred, there are several spectrums which can happen with Pol-G, and one of them is this ataxic neuropathy spectrum. It looks, at least to me, it looks possible. Only thing is we have to take away the father from this.
Yes, sir. I think I have to look into, sir. I really don't know, sir.
Okay, Mughaleshwari, it's all yours. And Ilangovan,
Sir,
you can finish, sum up.
yes, sir. Sir,
Yes, now what else you are going to do? What is your present thinking?
Sir, present thinking, I'm going for genetic testing only, sir. Actually, we advised coenzyme Q and all. And
Is it
later,
possible to do the Pol-G testing?
no, sir. No, only tablets we have advised, sir, but patient is willing to
Sir,
take, sir.
we can do, sir.
Okay,
Sir, further we will follow up, sir,
okay.
for his
Fine.
progression or whether he is static. And later again, we will take
Oh,
one
so long he
MRI
has
and
been static. For the last 3 years, he has been static only.
yes, sir.
Sir, should we repeat a nerve biopsy now, sir? Will it be contributory?
Yes,
Madam,
madam.
it depends on what we are looking for.
Yeah,
See,
there is definitely a
in this
sensory loss.
patient- In this patient, if anything is going to help us, it is going to be the genetic study.
Genetics. Yes, sir. Genetic study. You're
Nothing
not
else is
able to
going to
do
help
it.
us.
Yes, if you're not able to do,
Mughaleshwari,
Sir,
Mughaleshwari,
sir,
I asked you to talk with Madam Professor Anita Mahadevan to find
Yes,
out whether
sir.
she could give any clue.
Sir.
Were you able to contact her and talk to her?
sir, that myonuclear clumps, what we have discussed, it is due to now pathology only, it can give rise to myonuclear clumps, sir, in biopsy.
So if so, how do you fit in the nerve problem? Okay, so we still say it's an ataxic neuropathy, that is sensory. So
Yes,
there is
sir.
a motor
Yes, sir.
neuropathy component also, is it?
Motor neuropathy, but patient has no signs or
No, I'm
symptoms,
asking you,
sir.
ma. See, we are talking about Pol-G, we are talking of sensory ataxic neuropathy.
Yes,
We are
sir.
talking of this pathology, histopathology.
Yes,
So how
sir.
does that histopathology fit in with this?
Sir,
There are
we-
many things which we are not able to
Able to answer.
fit in.
Yes,
Sir,
sir.
he in sensory ataxic neuropathy of in this itself, because nerves are degenerated, this can give rise to that myonuclear clumps, sir.
That's what I wanted to find out from you. It can happen, is it?
Yes, sir. Yes, sir. It
Okay,
can happen,
Okay,
sir.
fine. That's what I wanted to know from you. Right, fine.
Yes, sir.
Madam, it's all yours. now.
Yes, sir. You want to go ahead? You got some more slides, Mangaleshwari?
No, madam. That's all, madam.
So shall we? Okay.
Yes, Madam Mughaleshwari,
She is putting
Ilangovan, and Banu Madam, thank you for presenting that very interesting case. And of course, the others who are.
So what do we conclude at present as our differentials?
As you
First
know,
one,
that's how we end the Wednesday morning meetings.
yes, sir. So Pol-G, first
Yeah,
one.
probably. That's
Pol-G?
my thinking. But
Yes,
I
yes.
do not know about. See, others will also have to concur. That is why we are presenting in this platform. to know how many share the views. It's not 1%.
No, I'm just asking. No, sir.
view.
I'm asking consensus. Do we take it as, I think because they also want some answers from the presenting unit. Do we take it as first possibility is apology? Yes? Yes from others or no from others?
No, madam, I would disagree.
Disagree. So what would be yours?
No,
Hereditary
madam, if you are
neuropathy.
the examiner and I had presented this to you, would you agree?
No. I would go for some HSN plus neuropathy plus hearing loss.
Thank
Though
you,
there is
madam.
some improvement
I
in
would-
between.
Madam,
Yes.
I would also go for the hereditary sensory neuropathy with associated hearing loss.
That comes in HSN type 1E. There is one type, but I don't know the full features. I was just looking up now. Okay.
Madam,
Yes, sir.
I have a doubt.
Yes, sir.
Yes, Professor Natarajan sir says exactly the patient presented with radiculoneuropathy. Father presented with proximal weakness, not
Yes, sir.
distal weakness or
Yes,
sensory
sir.
loss.
Yes, sir.
So that is against the hereditary sensory
neuropathy. No, we are taking only the patient because father's presentation seems to be a little different. The other thing is MEMSA, mitochondrial encephalopathy with motor sensory ataxic neuropathy. That is possible, but again, so far we have not got an answer from that. For that.
Okay, madam. Thank you, madam.
I have a question for Professor Meghandan, sir. Sir, Meghandan, sir, are you there?
He is there. He has to unmute
I'm here, sir. I'm very much here.
Yeah, you mentioned about hexosaminidase deficiency. If
Yes,
I am
sir.
right, hexosaminidase deficiency presents like an anterior horn cell disorder. It's a differential diagnosis for an anterior horn cell disorder. Am I right? So how
Yes,
does
Yeah,
that
yeah.
fit in with this patient?
Hearing, it is almost for almost like a Madras motor neuron disease, sir.
Yes, exactly. Agreed. Yes.
But
here the presentation
hearing
doesn't
impairment,
look like that.
So, sir, here we agree to disagree on the differential diagnosis, or we agree to the differential diagnosis and proceed with the next presentation.
Yes, madam.
Yes. Dr. Ranjita,
Yes, ma'am.
you ready?
Yes, ma'am.
Can you please go ahead
Ranjita,
with
present next case.
Yes, ma'am.
next case of myelopathy, right? An interesting case of myelopathy, Dr. C. Ranjita, Senior Resident, Department of Neurology, Government Chengalpet Medical College. Over to you, Dr. Ranjita.
1 minute, ma'am. Yes, madam.
Yes. Over to you.
Madam, are you able to see the screen, madam?
Yeah,
Yes.
we are able to see the screen. Maybe you can go into the presentation mode.
Yes, madam.
Yeah, we're able to see the screen.
go for PowerPoint presentation.
Yes, madam.
Yes. Please proceed.
Good afternoon, madam. I thank Department of Neurology for giving me this opportunity to present this case of myelopathy. Jagdish, 13-year-old male, presented with complaints of weakness of both lower limbs from 3 days and diminished vision in the right eye from 1 day. And patient was all right 3 days ago, and he developed difficulty in walking in the form of clearing the ground and not able to wear chappal. His weakness is progressive, and next day he developed buckling of right knee while walking. He also had difficulty in climbing upstairs and downstairs. And on the third day, he was walking with support, and he had difficulty in getting up from bed without support. He also developed difficulty in using both hands and was not able to grip objects, and he was able to lift his arm above head that day. Then he had no stiffness, no flailness, no cramps or fasciculations, and there is no history of muscle pain or spasm. No history of weakness in the upper limbs at that point of time. Then after admission, his weakness worsened and he was not able to sit and stand even with support, and he became bedbound. He also noticed diminished perception of clothes below the nipple region, and he had difficulty in appreciating hot and cold sensation below the nipple region while bathing. No history of any tingling sensation, burning sensation, no history of electric shock-like sensation while bending neck. Then he complained diminished vision in the right eye later, and he was able to perceive movements of objects but not able to perceive any details, and he cannot read with his left eye closed. Then history of pain on moving right eye was there, and no such complaints in the left eye. There was no history of redness, no history of watering, and no history of headache, no history of double vision. Patient noticed difficulty in initiation of urination, though he is able to perceive the bladder sensation and could not void, and there was painful retention, and he was catheterized later on. No history of constipation or fecal incontinence. No history of difficulty in perception of smell, or no history of drooping of eyelid, double vision, and no altered sensation of face, difficulty in chewing, no history of deviation of angle of mouth, difficulty in appreciating taste of food, no history of difficulty in hearing or no nasal intonation of voice, or no history of difficulty in swallowing or regurgitation of food, and no history of difficulty in shrugging shoulder. No history of difficulty in moving tongue inside the mouth and maneuvering of food in the mouth. There is no history of altered sensorium or abnormal behavior. No history of fever, headache, any vomiting, neck stiffness, diarrhea, or any exanthematous fever. No history of cough, expectoration, hemoptysis, or evening rise of temperature. No history of head trauma. No history of any rash or weight loss, joint pain. No history of substance abuse or intoxication or drug abuse, drugs usage or abuse, and no history of recent vaccination. Past history of no past history of similar illness, and no history of such illness in the family, and birth history is uneventful, and personal history mixed diet, and he's on mixed diet, and sleep is normal, bowel habits are normal. Summary: 13-year-old male with acute onset quadriparesis, progressive over 3 days, and onset bilateral lower limb weakness, then upper limb with diminished sensation for all modalities below nipple region, with diminished vision in right eye, with bladder involvement, and without bowel or cerebellar or higher mental function involvement. Madam, shall I proceed?
Yeah.
Any residents here in this forum? Anybody wants to discuss?
Madam, there is the history suggestive of optic nerve as well as cervical spinal cord involvement. Probably with a dropped sensory level at P4, with bowel and bladder involvement, it definitely shows involvement of the spinal cord. It could be a cervical cord also, along with an optic nerve involvement.
Yes. Yes. So acute onset.
Acute onset progressive.
Progressive over 4 days.
Probably suggestive of history suggestive of a demyelinating illness.
Yeah. Anything anybody else wants to discuss?
I think all of us would have to think of an NMO at present.
Yeah.
So, unless she is going to show something more.
Okay. Then I think we'll proceed to the findings.
Yes, madam.
Okay, madam.
Yes.
Because there is nothing much here
to discuss. Yes.
Madam, structures involved bilateral pyramidal tract, and
that's okay, madam. You go ahead with the examination.
General examination. Patient is conscious and cooperative and moderately built and nourished and oriented to time, place, and person, and there is no paler icterus cyanosis, clubbing, no pedal edema, no lymphadenopathy. Patient is afebrile, not dyspneic or not tachypneic. And the pulse rate was 78, regular rhythm, normal volume, no specific character. All the peripheral pulses palpable, no radial, radiofemoral delay or condition vessel was normal, and no bruit in carotid artery. BP is 110/70, Then respiratory rate is 18 per minute, regular rhythm, abdominal thoracic type, and temperature he was afebrile. Higher mental functions, conscious and cooperative and oriented to time, place, person, and memory is immediate, recent, and remote intact, and language spontaneous, comprehension, fluency, repetition, naming the word output and articulations normal. MMSC 30 MMSC scores. Cranial nerve examination, first cranial nerve is normal and second cranial nerve visual acuity, finger counting is absent, and he is able to perceive hand movement at a distance of 3 feet, and the perception of light is present. And in the left eye 6/6 vision was there, and the field of vision could not be examined due to poor vision in the right eye. It is normal in the left eye, and color vision was not able to recognize any color in the right eye, and left eye normal, and fundus is normal in both eyes. Third, fourth, and sixth cranial nerve, there is no ptosis, no extraocular movements are full, both eyes, and pupils are reactive 3 millimeter, and light reflex direct is sluggish, and consensual reflex is also present, and RAPD is present in the right eye, then accommodation reflex is present. Nystagmus is absent. Trigeminal nerve normal motor and sensory function, and reflex is normal. Seventh cranial nerve is also normal. Eighth cranial nerve is normal, and 9, 10 normal, and 11, 12 is also normal. And the motor system bulk is normal, and there is hypotonia, and upper limb pyramidal pattern of weakness 4+4- upper limb flexion is better than extension, and adduction is better than abduction, and elbow flexion is better, and wrist flexion is better, and hand grip is 50%. Then lower limb 1/5 power lower limb. Reflexes, superficial reflex, corneal, conjunctival are present, and cremastic is absent, abdominal is absent, and plantar there was no response bilaterally, and tone is normal, and deep tendon reflexes are all brisk, and extracranial system and release reflexes were not there. Sensory system, pain and temperature decreased below T4, and right side more than left side, and vibration and touch are decreased below D4, and joint sense impaired over the ankle and toes, and rhombus test could not be performed, and cerebellum test autonomic nervous system normal, and gait could not be tested. Summary: 13-year-old male with bipyramidal weakness, lower limb more than upper limb, and hypotonia of all limbs, and exaggerated reflexes with loss of all modalities of sensation till T4 level, with bladder fiber involvement, and right eye perceiving hand movement only.
At this time, it looks like what we have said earlier, NMO spectrum disorder. Anybody has any other differential diagnosis? Please speak up. Unmute yourself and speak up.
The
Otherwise,
presenter can identify the problem why she is presenting this
case. Yeah.
What is the unusual finding which you have made out, which prompts you to have a discussion?
Usually over a few days it will take for multiple sclerosis or demyelinating disorder to present, but within a few hours he had all the symptoms, and we
are talking about neuromyelitis optica, not multiple sclerosis like
sclerosis. Yes.
So another feature against neuromyelitis optica is the single eye involvement. Probably it's retrobulbar neuritis.
Yes.
In neuromyelitis optica, it's usually bilateral.
Bilateral.
Not necessarily at all.
Yeah. seen first presentation as just optic neuritis, subsequently as myelitis, and later
Okay,
also.
fine. So let's take on from there.
This is the first.
So what would be your differential diagnosis if it is not NMO?
Right. Adam, it could be Adam, sir.
Sorry?
Why
Adam. Adam.
Why? Why Adam?
NMO, it can be NMO or
That's it. Okay, NMO like presentation in Adam.
presentation.
But what was the history prior to the presentation?
Only,
Ranjita, you are Ranjita, no? Presenter.
yes, sir.
Yes.
What is that for E? A is there, D is there, M is there. What is there for E?
Correct.
He,
Ranjita, can we see you?
madam.
I-
Video is
put on the
not
video.
working, ma'am.
Okay.
Don't bother. Go ahead.
Okay.
Okay, you proceed anyway. Let's see what,
Yes,
what
sir.
makes you
Present
what makes
here.
it interesting.
Neurological deficit, this what I discussed, madam.
Okay.
And investigations, normal CBCN
Okay.
peripheral smear and
ESR normal, not
everything else is
contributing.
normal.
Okay.
Chest X-ray is normal, ma'am. CSF
Okay,
analysis,
Okay.
normal OCD is negative, and aquaporin 4 and MOG also were negative.
Okay.
This is the report. This is the radiology.
Yes.
Axial T2 hyperintensity in the cord, C2 level, and
There's something in the cord there.
Yeah.
sir,
That's what she was telling, sir. Hyper intensity in the cord at C2.
Yeah. Okay. Fine. One sided.
and another image diffusion restriction, subcortical,
Multiple.
frontal, and T1 cord, T2 hyperintensity at C2 level. Orbit, no significant abnormality detected in the orbit, and T2 flare hyperintensity.
No. Can you show me the previous report? Sorry.
Sir, I wrote.
Suspicious.
Yes, sir. Okay, sir.
Sir, actually, can we see the cord little enlarged? Can you enlarge it and show Ranjita the image?
Yes, ma'am. 1 minute, ma'am.
Even previous. Okay. Can you, yeah. Can you enlarge it? Okay. This is only on left side. Right. Next one. Just take it up a little. Okay. Next image. And go to. Yes. Okay. Next one. Oh, multiple. How many are there?
One
Very
is
well.
parallel, one is perpendicular to the ventricle, madam.
Okay,
One
one,
demyelinating
two,
clock.
I think I'm seeing 3, or is it
3.
more? Ranjita, is it just 3
Yes,
or
ma'am.
more?
Yes, ma'am. 3,
Okay.
3, ma'am.
Okay,
3.
then next. Yeah, next one. Okay. Okay, different place. Next one.
T1.
Okay.
Any coronal or corpus callosum?
I don't think they have that image, sir. It's not shown here. Can you enlarge this?
Yes, ma'am.
Yeah. Can you just point out from where to where?
Yes, ma'am.
Yes. That's it.
Short,
Ma'am.
short extent involvement with the cord
not a-
swelling.
Yeah, not a long segment. That's why I just
No,
wanted to see.
short extent, short segment involvement.
Sir.
And high cervical.
Yes, ma'am.
Yes. Yes. Now please go to the report. Sir, what a report I have. It's a mildly expansive lesion was cranial caudal length at 5 millimeter APV. See in the spine cord C2. Okay. Next, please. Okay. Please go ahead.
Yes, ma'am. Course in the hospital, patient was treated with IV methyl prednisolone 500 milligram OD for 4 days, and he did not show any improvement of symptoms, ma'am.
Okay. So this is what you're presenting for. What is the reason for your presentation? Do you have any particular queries?
Madam, pediatric age group.
Hello. Yes.
Pediatric age group and presenting with demyelinating illness, which is not over the days, but somewhat over within 1-2 days, he had all the symptoms.
Does it rule out a demyelinating illness?
Madam?
Does that presentation rule out a demyelinating illness? Course over 1 or 2 days?
Madam?
Yes, sir. Please go ahead.
Madam.
Tell us for what you are presenting.
Okay, madam.
Okay. Because I think most of
Madam,
us
we
will
presented the
diagnosis of-
case. Madam?
Yes, sir, you're audible.
We presented this case because young boy with anxious parents with acute sudden worsening, aggressive form of demyelinating presentation with myelopathy and optic neuropathy within 2 to 3 days worsened and not responded to methylprednisolone. And interestingly, his patient had 1 to 2 segment cord involvement, optic nerve involvement, and picture first episode. So that in the forum they to decide whether we planned for IVIG or plasma exchange, go to the next step. What's your idea, madam? That's what is a multiple sclerosis aggressive presentation in the pediatric age group. And whether we can go to the diagnosis itself with this presentation.
What was the CSF protein?
CSF, put the slide.
No.
Ranjita, CSF protein
Yes, ma'am.
was how
Yes,
much?
ma'am. Yes, ma'am.
No, was it elevated? I forgot.
No, ma'am.
Everything negative, madam.
Okay,
Aquaporin
what about
negative, MOG negative, oleoclonal band negative.
Yeah, that I remember.
Normal
Protein is only
CSF.
46. And how old is this patient?
13 years.
13
old,
years.
ma'am.
13 years. I don't know pediatric criteria for multiple sclerosis. Sir, Megandan, sir,
Yes, sir. Yes, madam.
do you think this is MS or not?
There
Or do
is
you
a
think
strong
this is
there's
or
a strong
NMO?
possibility. It can still be NMO, madam. It can still be NMO because anti-MOG, MOG and aquaporin may be negative.
Negative, yes.
Initially may become positive and various types are there.
Yes.
And what we are in view of the absence of OCB, it's more of NMO type of disorder.
Yes.
And the initial response may not be there for steroids.
Host, can you mute the others who are not speaking?
We have had more of brainstem type and this type of NMOs in children quite commonly, not other types. And this is quite. What about the VEP in this case?
VP not done, sir.
VEP not
Patient is
done.
in ICU, we are not able to do that.
Why is he in ICU?
because patient is quadriparesis and is may go for respiratory distress. I think so. So we watched it in the ICU, madam. Monitored in the ICU.
Madam.
Yes,
Madam,
sir.
and MRI picture, whether it's androlateral, predominantly lateral involvement of the cord in 1 to 2 segment. I think is more favor of MS rather than NMO. What is your opinion, madam?
Yeah.
It's a short segment. Yes, sir. Yes. I think
And
somebody is
androlateral
answering.
predominant.
Okay. Yes. Somebody was answering. I butted in. Please go ahead. It's come here
Madam.
as Dr. D.K. Nagar. Who's that?
Madam Ramakrishnan speaking, madam.
Oh, yes, please, Ramakrishnan. Go ahead.
Madam, see the MRI, there is some of the segments, it shows involvement of brainstem also, madam. I am not fully convinced about the diagnosis of pediatric MS, madam. And CSF oligoclonal bands, generally, if you see, it is 70 to 80% of the time, it will be positive in MS, madam. Whereas in NMO or MOG, the positivity rate will be only 30 to 40%. Yes. And so I and this anti-aquaporin 4 antibodies, if what we generally do is with the ELISA, madam, that is not the test which we have to do. Actually, it should be based a cell-based assay. That is much more sensitive. So if you have done with the ELISA test, then just because the test is negative, we can't say that this is not NMO, madam. And the treatment-wise, I think we should go get with plasma exchange, madam. Somebody has got a quadriparesis. Actually, now the recommendation is to do plasmapheresis along with steroids, madam.
Okay. I would go with probably an NMO spectrum, though it doesn't classically have that long segment. To call it MS, I may be a little hesitant. Routine is negative, no oligoclonal bands. Of course, the newer criteria are different. And I think we need, what about the contrast was there? How many contrast enhancing lesions and non-contrast? Any new old lesions seen in contrast scans?
No old lesions.
Huh? No
old lesion, madam. Only this lesion, only and.
No, all are enhancing lesions. Contrast enhancing. Hello?
Yes.
Madam, if I may.
Yes, Vijayan. Yes, Dr. Vijayan.
Madam, doesn't fit in with either NMSOD or MS.
Okay. Nearest, then you please tell.
At this stage, with this much of investigations and MRI present picture, I don't think we can either call it MS or NMSOD. Okay. It's a monophasic demyelinating illness as of now, and we'll have to look for the causes. Now, it can be inflammatory, it can be infective inflammatory, it can be non-infective inflammatory, and it can also be sometimes toxic. I think we'll have to explore all other possibilities before branding this as either NMSOD or MS.
Would you call it Adam?
Again, it doesn't exactly fit into the criteria of Adam. Then the MRI doesn't fit into
it doesn't look like
Adam. Illness.
It doesn't look like an Adam.
It doesn't look like Adam, madam.
No. MRI doesn't.
MRI is very classic.
MRI doesn't look like Adam.
Look like Adam at all. Yeah, I agree.
It's a monophasic demyelinating illness for which we have to probe the cause. That's all.
But how else? What else should we do?
It can still be NMO. It can still be. Because we have had cases like this, and aquaporin may become positive, as he said, that if it is not from ELISA, it has to be approved from other things. And we have had cases of negative anti-MOG aquaporin, as he said, that responding to plasma exchange. They are very, childhood presentations are very, sometimes even the cervical cord enlargement, initially it looks like a small one. Third or second of MRI has shown little more extended long segment involvement. This we have seen in children quite commonly. Though it's not a progressive disease, it can be. As he said, it looks monophasic. That is the only thing which is little.
And the lesions all from what they present is all the same time. There's no dissemination in time.
But clinical presentation is very classic.
Very classical.
Very classical presentation. It's very.
Anu, madam.
Yes, sir.
Can I make a comment?
Definitely. I'm just calling you only, sir. Please go ahead.
See, with regards to whether it's a monophasic or multiphasic, we'll have to wait because it's too short a time to conclude that it is a monophasic illness. Second, regarding the question which she raised, Ranjita, whether this is acute. Yes, certainly demyelinating lesions of NMO and MOG will be this acute only, or ADM also. Only if there is nothing unusual about it being so acute. Third is the MRI picture. MRI showing only one part of the cervical cord being involved, not the entire cord, and also confined to 2 segments. Yes, it is not the classical LETM, which is associated with either NMO or MOG. Fine. But as Dr. Meghandan already pointed out, we'll have to wait for the picture, but it's not, I mean, essentially, in this, we will conclude that it's a short segment, unilateral, partial cord involvement. Yes, agreed. Let's have a differential diagnosis for that, which necessarily will include MS, but there's no clinical data to go with MS. Now, coming to the MRI abnormalities in the brain, it's a parenchymal involvement. And it's not in the area which normally would be associated with NMO. But this sort of parenchymal makes Ranjita to raise the possibility of an ADAM. But such presentations are well known to happen with anti-MOG syndromes. So my provisional diagnosis is this is an anti-MOG. And for reasons that already has been said regarding NMO antibodies as well as MOG antibodies being absent, we have to go for a cell-based assay, without which we cannot conclusively say it is present or absent. So provisionally, I think it is it. Now coming to the treatment part, I think based on weight, they had given 500 milligrams, but probably 5 days would be in order. And as Ramakrishnan pointed out, the next course would be plasma exchange or IVIG. So that is what we need to go on to. Certainly that is indicated because the patient has not improved at all. And going by past cases with regards to both NMO as well as MOG, and Vijayan is very fond of this, is to give Rituxi. Rituxi just melts it. I would go for a Rituxi straight away rather than, I mean, this is not necessarily evidence-based rather than, but probably having seen cases, rather than plasma exchange or even IVIG, I would favor Rituxi. What do you say, Vijay?
Sir, yes, sir. I will have to be more aggressive. I think, as TCR pointed out, next course would be Plex. And if Plex doesn't work, yes, probably Rituxi.
Oh, you want to go straight to Rituxi?
Plex first, sir. Plex.
Yeah, you are the more aggressive person, pa. You always go for Rituxi.
I usually go for Rituxi after consulting TCR and Jnanashanmugam, sir.
Oh, playing safe. Okay, PCR. Why not Rituxi
Immediately?
Sir, there's no
straight away?
Sir, it will take time.
In pediatric practice, what do you feel about giving Rituxi?
No, sir, I'm not in favor of Rituxi, sir. It will take time, sir, at least 2 weeks for it to act, sir. Plasma exchange will be the next better one, sir.
But the cases which Vijayan has presented did not
Yes,
take
sir.
2 weeks.
Yes, sir. Yes, sir. But personally, no, sir, I would go for plasma exchange only, sir. Not for Rituxi right now.
Ramakrishnan, how many exchanges should be planned?
See, in pediatric,
Sir, it is based on the body weight.
Ram, Meghandan wants to say something. Let Meghandan say, and then you come in.
Rituximab in pediatric, we have burnt our fingers, sir. We have not had a good response to any of the illnesses. Yes.
Sir,
How many exchanges should be planned for the
Dose of
Sir,
exchange.
it's 50
Is it
ml
the
per
adult?
kg.
Is it same as the adult or lesser, much lesser plasma exchange? Rate
Madam,
of exchange?
Same as adult only, madam. 50 ml per kg, madam, per exchange. To a total of 200 to 250 ml per kg body weight, madam.
Okay. Over how many days? 2 weeks?
Yes, madam. On alternate days, we have to do, madam.
Okay.
Probably 10 days or 14 days.
Okay.
I think Ranjita wanted to say something.
Sir, it's Moglishwari, sir. I have a doubt, sir.
Yeah.
Sir, is it, shall we consider this as a steroid resistant, sir?
See,
is there any entity, sir?
Not steroid resistant.
Yes, sir.
Not all NMO or MOGs respond to IV missile prednisolone. This is very well known. Particularly NMO do not respond.
Yes,
so
sir.
that is why we need to go for the next options.
Yes,
Next
sir.
options have been IVIG and Plex.
Yes, sir.
Wherever plex is considered a bit difficult in the sense, technically difficult, people go for IVIG.
Yes,
But
sir.
based on adult population, based on what has been shown, particularly by Vijayan, in
Yes,
this
sir.
sort of setting, Rituxi seems to help. So now more
Sir,
and more
I'm not a pediatric
patients are being
neurologist.
taken to Rituxi. Enna Vijayan?
I'm not a pediatric neurologist.
I know. No,
maybe in
I
Jashwin's.
prefixed it to saying in adults.
I just wanted to add that maybe in Norman Jashwin's description, I can qualify as a pediatric neurologist because I carry inch tape with me. Thank you.
Sir. Sir.
Solanga
Sir.
Magaleshwari.
Sir, after steroids, if it is not responding, is it next without plasmapheresis? Can we go for immunomodulating like immunosuppressants like rituximab, sir, or should we consider plasmapheresis later? We can go for rituximab, sir.
I'll tell you my view.
You can try IVIG.
Traditionally,
sir.
Traditionally, it will be once IVMP fails, it will be IVIG or plasmapheresis, depending on what is feasible.
Yes,
but
sir.
Then, if both of them do not help, we go to Rituxi.
Yes, sir.
That's been traditionally, that is what is. Sometimes we are prompted to go to Rituxi because of its good efficacy. That's all.
Yes, sir. Yes, sir. Thank you, sir.
Sir, good afternoon, sir, respected sir and madam. Sir, I'm Dr. Prakash, second year PG, sir. I have one doubt, sir. Actually, some of the guidelines have given if steroids fail, we can try for ACTH, particularly in update literature review. So, is this ACTH useful in these conditions, sir?
I leave it to Meghandan and Ramakrishnan because they are the pediatricians.
Yeah.
They use more of this ACTH rather than us.
Sir, I don't think that ACTH will be useful in this type of setting, sir. We have to go for either plasma exchange or immunoglobulin, sir.
Okay, sir. Thank you, sir. One more doubt, sir. Should we have to rule out other secondary causes like autoimmune vasculitis, those kind of disorders in this initial setting itself, or if after the initial crisis is tied over, we have to work up for other causes, sir, or what is that doubt we had because the patient was worsening in spite of all the steroids?
I think we have to work out. That is what I feel, sir. Because whatever so far we have done, the results have not given what we think. Plus, VN sir said it's clinically and imaging wise like an emoji antibody disease. But
Okay,
our emoji antibody test is negative. So in this circumstance, we have to rule out. If it has come positive, then probably we need not do. That is my opinion, sir.
You try to repeat the emoji.
That's actually I was about to ask that question, sir. After how many days should we repeat it?
There's no fixed time.
Is it 2 weeks or something like that?
No, madam, I don't think so. There's a fixed time. Maybe others can also say. Yeah, but it's.
I was wondering if it's negative first. Do we give some sufficient time?
So usually repeat is done after 5 days. Usually, but I do not know whether there's a specific cutoff for that. And again, Ranjita, was this emoji done on serum or CSF?
CSF, sir.
Pardon?
CSF serum.
Both, sir.
Come on, both or CSF or serum?
Both, sir.
Was done on both.
Yes, sir.
So perhaps you can repeat one. And I am not very sure, but cell-based assay is done in some labs. So perhaps it is worth still to have a cell-based assay because a definitive diagnosis can be arrived.
Yes, sir.
Thank you, sir.
Meanwhile, they can go ahead with the plasma exchange, sir.
That can come. Why should we wait for this? Why should we wait for this?
No, just since they wanted an answer, I'm just making
sure. Serum தான்ப்பா போட்டிருக்கு, blood தான்ப்பா போட்டிருக்கு.
Serum only, sir. Serum only, sir. CSF oligogonal band only.
CSF ல அது பண்ணல இல்ல?
பண்ணல.
பண்ணல.
Again, it's a debatable issue whether CSF is going to add, but perhaps that can also be because It's not anyway. It will give us a follow up also on the CSF finding, and if she is not very, if the person is not very reluctant to have a LP done again, perhaps we can try on CSF and also send it for CSF. I'm sorry, cell-based assay.
Okay.
But I think treatment wise, we go ahead with the treatment, irrespective of whether we are doing this or not, because it looks clear cut that it's a demyelinating illness of probably MOG or NMO. Based on the brain findings imaging, I would go for an MOG rather than NMO. That's all. And they should respond. But this response to IVMP is not at all unusual with NMO spectrum disorders. This is to be expected, and we'll have to go further up, either as to IVIG, plasmapheresis, as they've said, or rituximab. I won't be surprised if Flex is also not very effective. Somehow in these NMO, I think the medicine which works best is rituximab. But I'm subject to correction.
Yes, Dr. Ilongavan, anything else you
Yes,
want?
sir. Thank you, madam. That's why we interestedly presented. Thank you.
Yeah. Very nice case presentations. Both the cases presented well. Congratulations to the neurology department.
Mugileshwari and Ranjita.
Ranjita, Mugileshwari, and to the HOD and the assistant professors, Dr. Ilongavan, Dr. Balaji, and
Department of Neurology of Chengalpattu Medical College.
Yes, sir.
The new kid on the block. You're doing well. Continue, please.
Thank you, sir.
The other day also the case was good. Sir, that
Yes,
you
ma'am.
had, yeah.
Yes,
Very
madam. Last
Yes,
month
sir.
itself, sir.
Yes, sir.
Last month itself, we had a tough period. 2 cases of post-vaccinal GBS, 2 cases of NMO like this presentation. We given 4 cases IVIG in 2 months.
Yes.
So here somewhat common, I think so. Autoimmune coming.
No, but what happened? What is the response?
That patient completely recovered. NMO patient. Last week I presented in the neurology checks. They presented improved well.
Okay. No, you
Vaccine
said
also
patients.
improved. All patients improved, sir.
Okay. Were they NMOs?
NMOs improved well with the IVIG, sir.
Okay. IVIG. Yeah, correct.
Ah,
Fine.
yes,
That's
sir.
fine. Yeah.
Okay.
Right. Those patients you gave methylpred also initially?
Yes, sir. Yes, sir. First you started with the methylprednisolone, then you continue with the oral
So they
steroid
did
after
not
IVIG.
improve with IVM. They did not improve with methylpred, and so you went for IVIG.
Yes, sir. Yes, sir.
Yeah,
Yes,
correct.
sir.
That's what happens with NMO. They don't improve that well with the methylpred. Yeah.
Okay, sir.
Thank you, sir.
Thank you.
Thank you very much.
Thank you, sir.
Thank you very much.
Thank you, sir. Thank you.
Thank you.
Thank you, sir.
Manu madam, thank you very much.
Sir, my pleasure is mine, and I thank you, sir, for this
No,
opportunity.
thank you, Meghanad sir. Thank you, Vijayan. Thank you, Ramakrishnan. Thanks, Anand. Thank all those who participated and made the discussion lively. The presenters, Ilangovan sir, Balaji, all of you, Department of Neurology, Chengalpattu, thank you very much. And
Thank
so
you,
also a great thanks to Sun Pharma,
Thank you, sir.
without
Thank
which
you,
this
sir.
forum will not
Thank you,
be
madam.
functioning. Thank you very
Yes.
much.
Thank
Thank you,
you.
madam. Professor Banu madam, thank you.
Thank you. Thank you, sir.
Welcome.
A
madam.
pleasure, sir. Always been a pleasure.
Thank
Thank
you.
you. Thank you, all of you.
I should say the same also. It's reciprocated.
Thank you, sir. That's nice.
Thank you.
Thank you. Sir.
Finally, can we leave?
Yeah, sure, sir.
Thank you.
Thank you.
Thank you, sir. Thanks a lot.
Thank you.
Moca,